I am delighted to introduce our next speaker. So this is Rasmus Bech Hansen, who is CEO and founder of Airfinity, a company that specializes in disease forecasting. And in his talk, Rasmus will consider how the world will fare with a new pandemic today. Rasmus, welcome.
Hello, everyone. In case you wonder, I am the 27.5% guy that Tony Blair talked about. So we have that clear. Well, first of all, thank you very much for the invitation to be here today. Thank you especially to Sir John Bell, I don't know where he is, but who encouraged us to do the modeling we'll be sharing today and inviting us here to speak. It's a great honor for me to be speaking in this forum. I'm a very big admirer of the Rhodes Scholarship, and we as a company ourselves have benefited tremendously from some of the talent that comes out of the Rhodes program. So I'm grateful for that. There is some truth to the saying that what gets measured gets done, right? And I think when it comes to pandemic preparedness, pandemic measures, pandemic risk assessment, that is very much the case. So what I hope I can help with, and the way I hope we as a company can contribute, is to put some data on the table on that can help inform discussion on how much to invest in pandemic preparedness and in what measures to invest in. And I put a lot of data, share a lot of data today, and of course there's a lot of uncertainty around that data, and the 27.5% is a bit of a joke. Of course, no one can measure it that precisely. But that being said, we do have a tremendous amount of data now after the COVID pandemic. It's no longer a guessing game for us to see how would a pandemic play out in a modern society. We actually know that. We have detailed data, we have detailed time series data. So I think what we're facing now is that lack of data, lack of evidence, and lack of a precedent, that is no longer an excuse for inaction. Let me see how I get this one. So I don't want to go, just say a few words about us, a company, for those of you who don't know us. We're an independent health analytics and data company. We have played, I think, an important role in the global pandemic. We tried to put out as precise and accurate data as possible from the very early days. We work closely with a range of governments, UK amongst them, in their pandemic response. And really, as a company, our North Star and our goal is to create a better real-time forecasting solution so that the world knows at any given point of time what is the true level of disease, starting with infectious disease, but potentially also broader, and then also starting to have a better systematic real-time way to forecast the disease and disease outcomes. I should say that we just last point on us, if any of you bright Rhodes scholars out there ever looking for a job, please come to me afterwards. But following on from especially John's presentation earlier, I would very much agree with the fact that COVID-19, of course, was a huge disaster, but and it still is, by the way, a massive disease burden, and we should really not forget that. When we do some of our forecasting on future burden of disease from COVID, the picture is not pretty, very far from. But I think it's also fair to say that it could have gone worse. So one of the things we would try to model is how does bad really look like? And one scenario, if I may ask you just to use your imaginary head a bit to think about what would have happened to the world if the wild type virus came out of Wuhan had been as transmissible as the Omicron virus, right? We know that Omicron is more transmissible, slightly less severe. So a less severe, but much more transmissible virus. If that had hit a globally naive population, how would that have looked like? And I don't think that's a far-fetched scenario. There's no reason why the first wild type could not have been Omicron, or could also have transmitted, let's say, in a more closed community before, and then mutated to that level before then going global. So I think this is a pretty realistic scenario. And so what we modeled here, we've done it for the UK, I should say, because these are quite complex models to do. So do it globally is a very big task, but it makes more sense to do it by country. And for the UK, we have very detailed data. So what we're looking here is, if you see the graph to the left, you can see that at the peak day, and for those of you who lived in UK at the time, I think we can all remember how dark those days were, right? When there were around 1,000 people dying a day. That number would, according to the model, have been 5 times higher. So 5 times higher. Imagine the pressure that would have been on the UK health system. What a disaster that would have been. In the first year, we would have seen 300,000 deaths instead of 100,000 deaths overall, if that scenario had been played out. So just a somewhat of a change in transmission rate from Omicron, it would have been a very different pandemic we would have looked at altogether. If we then try to extrapolate that on a global level, global mortality figures, of course, is we could have a whole session on that. So I took both the official numbers and the estimated excess death. We personally think the excess death numbers are the most accurate way to think about mortality from COVID. But if we take the excess death, then almost 15 million instead of 6 million would have died globally if Omicron had been the first one to hit in year 1 alone, right? So that is a very, very serious situation, even worse than what we have seen. Then let's go one step further and look at something that could have been even worse and how that would have played out. So I think you probably all aware, I've seen the stories around avian flu. So avian flu, H5N1, is a very serious disease, very high case fatality ratio. So far, it's not transmitting human to human, but let's just imagine a scenario where that virus mutates in a way where it starts to transmit from human to human, becomes airborne, gets a transmission level around the same level as the COVID wild type. How would that then look like? And here we're looking at, I would say, an absolute disaster, right? We're looking at 15,000 daily deaths in the UK alone. So can you imagine that would have meant a complete breakdown of our health systems here, if you looked at those numbers. And of course, you can't model that in the same way. It wouldn't be over a long period of time. The reactions would have been very different. People would have adhered to stricter rules, etc. So what we've done here is looked at it more in just a 6 months period. I think that's more realistic. And in that 6 months period, 600,000 people would then possibly have died in the UK alone. So a very, very grim picture. And globally, we would get up to 15 million deaths in the first half a year. So that is really, if you ask, what does bad look like? That is how really bad looks like from a pandemic perspective. I think the point here is this is not a science fiction imaginary situation, right? This is a very real threat, as I think some of the speakers have already pointed out. So if you look at the number of outbreaks we're seeing over time, what this graph shows is back to 1855. What are some of the major outbreaks we have seen over time? And what you can see is that to the right, the more you go to the right, the more of these outbreaks you have. So one could argue, okay, they might be mostly because of we are testing better, etc. But I think there is a real case to be made is that these high-risk outbreaks that could potentially become pandemics are more frequent than they have ever been before. So, I've looked at our global health briefing this morning, and a virus like the Marburg virus in Africa is spreading certain places, very, very lethal virus, just one example. So if you start looking into that picture on a regular basis, you realize that there is a lot of high-risk viruses out there, and they don't have to mutate a lot. Not a lot has to happen before that becomes a very risky situation. And as has been pointed out, if we look, this is one of the concerning things, if we look at what measures do we have as a society to mitigate that, then what this graph shows is some of the highest risk zoonotic viruses. How many of these do we have working vaccines against? absolutely love John and his vision for broader adult vaccination, but I'll just say the situation we're in now is that for most of these viruses, we don't have an approved vaccine. We don't have a vaccine that is proven to work, and of course the work that SEPI and many governments are doing hopefully will change that, but this I think is an indication of an underinvestment in this area for a long time. What are some of the underlying drivers of this? Why is it that we are seeing a more frequent emergence of high-risk viruses? Why is it that that we think that the risk of a new pandemic is higher than there's ever been before? So some of the things that drives this are the global population size, for instance. Age demographics is a factor, population density, but also clearly things like global temperature and climate change, deforestation, global meat production. Those are proven to be correlated to risk of viruses. So what we try just simply to put here is the redder it gets, the more higher risk it is. There's also some things that point in the other direction. So the total global health expenditure has increased, and that of course reduces the risk reduces risk of a pandemic, but also enables us to better deal with it if it happens. And I also think basic sanitation and things that are going in the right direction. But overall, even if you take those positive versus the negatives, the picture looks more red as we go along. So to understand this in a more detail and put some numbers on it, what we've done here is we have looked at all the major high-risk viruses, and we mapped out on one end you have the case fatality ratio. So the higher you up there, the more severe the disease is. On the x-axis, you have the R0 number, so the transmission rate. And there is, from a virus perspective, there is a certain trade-off between a virus that is killing everyone it gets in contact with, would not really spread, right? And typically the very highly transmissible viruses have lower case fatality ratio. So we can use this correlation between case fatality ratio and R0 to estimate future viruses. And basically that's what we've done here. So we created a model where we simulated 150,000 different viruses and spread them out using what the known relationships between transmission rate and case fatality. We then took different account into different starting outbreaks, population size, initial response. So took a lot of those other factors in, and then modeled that, simulated those 150,000 case potential viruses, potential outcomes. So pretty much an insurance model, and anyone who's interested would love to talk more about it. We also have some of our data scientists here today that can discuss it in more detail. So I'll just do it a little bit high level here, and get to the key slide, the key conclusion slide. So if we model these potential future scenarios, what we are finding is that a COVID-19-like outcome has a around 15% chance of happening in the next 5 years, and that equates to this 27.5% in 10 years. A Omicron scenario, as I showed before, has a 1.3% chance, so still pretty high, and then the further we go out, the higher the mortality, the less likely it becomes, not surprisingly. But still like a 0.1% chance of the H5N1 scenario. So I still say that that's fairly high. And I think when you think about pandemic preparedness, how much did the world invest, etc., I think this model could be really useful. We know for the insurance industry, in the insurance industry, regulators have set some clear rules for how much an insurance company should protect themselves against things happening, right? So why did no insurance companies go out of business during the pandemic? Well, because they were forced to have certain capital requirements if that happened. And the EU regulatory framework on that, called Solvency II, has stipulates that around 1 in 200% cases, so a case that might happen 1 in 200 times, would be needed to protect, the insurance company would need to protect themselves against that. So from that perspective, you could then say most of these cases would actually be, the world should protect themselves similarly against that. Or another way of putting that, if the world currently was an insurance company, one, it would have gone out of business during COVID, or two, it would be forced out of business now because we don't have that level of protection, not even close. We don't even have the protection levels of a 1 in 30% chance as we're showing here. So I think this is quite a startling and very important picture for decision makers. And of course the point is also, which is super important, is that this can be mitigated. If we look at COVID-19 outcomes, I think this is incredibly interesting, and there's so much more research that should be done into this area. But what is startling is the difference in outcomes in different countries, right? And some of that difference in outcomes can be explained by population size and other things that are native to that country. But most of these things cannot be explained by that. And fundamentally, it was the same virus that hit the world. There's certain differences now in variants in different countries, but that also doesn't explain it. Really, it is things that countries have decided to do or decided not to do that explains it. And I just want to point out that the excess death numbers, the difference here is really, really remarkable. You can see New Zealand, for instance, that had the zero COVID policy, waiting for people to get vaccinated before opening up, has had a absolutely extraordinary outcome and saved a large number of lives in that country. I think that's worth taking a lesson from. So what are some of the drivers? If we look at correlation coefficients to this excess death outcome, we're seeing that hesitancy, vaccine hesitancy, is very high. So countries with high vaccine hesitancy typically perform worse. Number of hospital beds per capita is an important driver. Median age of that country, testing capacity of the country, very important. Health expenditure as a percentage of GDP. And then overall kind of wealth of the country, so GDP per capita, also very important. And then, but the most important is total vaccinations per 100 people. So what this really says is, if you look at these parameters, which of the ones are what you would put in the bracket of pandemic preparedness? I would argue that total vaccinations, definitely. Testing capacity, definitely. Hospital beds, you could maybe say kind of some health resilience could also be put in that. So a lot of these factors and combating hesitancy, of course, is also a potential public measure one could take. So a lot of these things can be done and would just require investment. But we know that they would have a positive outcome. That's no longer the discussion. And I think it's quite remarkable to see how big an outcome it has had during the pandemic. So if we, again, just closing off here, trying to put some numbers on that, what would be that risk reduction? So we had the percentage chance of a new similar to COVID pandemic in the next 10 years being these around 27%. How much would that be reduced to? And that's what you can see here. So the purple line below the blue line. And what you can see is that is actually being reduced to 8%. So what we try to model is this happens, but we have achieved the 100-day mission. We have vaccinations that can be rolled out, etc. We have better testing capacity. Then that chance of that happening, similar outcomes to COVID, would be much, much lower. So a 70% risk reduction is achievable if we had a global pandemic preparedness set up. I think that is, again, a very significant finding in these studies. And of course, one can always discuss, the exact numbers, but there is no doubt that risk would be reduced massively. And as Tony Blair said, this pandemic has cost maybe $12 trillion. So I think a question I would like end my speech with would be, what would that be worth to the world? What would it be worth to the world to reduce the risk of a pandemic from maybe a 27% chance in the coming 10 years to just 8%? I would argue that that would be worth a lot of money and would merit a huge amount of investment across the globe. So, yeah, thank you for listening in, and look forward to taking a few questions on this.
Now it's time for all the technologically able to shine. So you're welcome. So it's the same link to use for questions throughout the day. Let me see if I can also be slick and technologically able and switch this iPad back on. If not, I might just, here we go. And if anybody is struggling with the app, during one of the breaks, you're welcome to come to any of our teams and we can help you troubleshoot. So a question that we have is just from someone who said, as a public health physician, it was incredibly important for their team to understand when exactly the pandemic or the next wave would hit, and so that we can be prepared for in time. So obviously modeling plays a big role, not only in predicting what type of pandemics to prepare for, but also to give insights on what shape the pandemic will take. Do you have any reflections on that, Rasmus?
No, that is clearly the case. I think that getting public support for some of the pandemic preparedness measures is a really difficult thing. Although I'm very supportive of the idea that we detect pathogens very early, and we, through genomic sequencing and potential through the use of AI, are better to understanding what is the risk of a given pathogen. I also think it's pretty clear that to get the support, then, so say even your magical AI machine tells you that new pathogen is of huge risk, So we say, okay, we're finding the Marburg virus that now can spread more. What would the world then do? It probably wouldn't do a lot until it was seeing that spreading more, at least in a confined area. So what I do think needs to be done is that we combine the genomic sequencing and understanding in more real time with better epidemiology data. I think it's been great to see that there's so many countries that have started to share their data. In fact, we couldn't exist without some of that data sharing. But I think there's more that could be done. It could be done in a more standardized, more structured way. I also think that we could start using alternative data signals more. I think there's a lot of things like wastewater has been mentioned that is really exciting, but also I think now at least many have digital devices. We start to have things like potential temperature in a population group. Globally, really interesting biomarker for infectious diseases. I also think that social media, although I would agree that it's a big source of misinformation, there is also informational value. And there has been some interesting studies looking at, for instance, searches on cough or bad temperature or things like that, that's proven to be correlated to some infections. So I think we need to be thinking creatively about combining some epidemiology signals with the sequencing. I think that's really important. I also think that one point I maybe should have made is that if you look at the cost, what are some of the pandemic preparedness costs? One that really stands out is the testing. So I come from Denmark, and Denmark had this policy of basically testing everyone once a week, right? It was a bit of a, everywhere you went, there was like the testing centers. And I think in retrospect, you would look at that and say, was that really necessary? Was that wise spend of money? I think the answer is no. I think you could have gotten a lot of that information much less expensively in different ways. And and I just don't think, although testing are going down, I don't think it's realistic for us to keep to test everyone all the time.
Fantastic, and that's actually a perfect segue into our next panel that will dive more deeply into what does this always-on solution look like in practice? So thank you so much. And also, Rasmus, for giving us figures to hang a hat around. So I think it's much easier to mobilize action if you say, we've got a 27.5% chance of another COVID-19 pandemic in the next 10 years. I think that's really something to have a rallying call and get people to act. So Rasmus, thank you very much. And thank you for the fantastic work that you presented today.
Okay, thank you.